Hey guys, welcome back to another episode of the Gate Guys podcast. Sean Allen here in Chicago. We'll be on the line with Dr. Ivo in a moment. We're going to keep this short and sweet today. Had a lot of technical problems with this podcast, more than we ever have. The audio levels are off. There's something wrong with Ivo's mic. I don't know if it queued up his mic properly or just used the mic on his laptop. But it is horrendous. But the information, I think, is still valuable. And rather than scrapping this podcast, we decided just to put it out as naked and vulnerable as it is and let you guys just take in some good information that we felt was pertinent. We also ran into some software not running on one end of both of our ends actually during this podcast. So we had to do a little bit of editing and clipping out some stuff. So there's going to be points where it seems choppy. Hey, sorry about that, but it's worth it not to scrap this and just send it out. So no commercials. No muss, no fuss. We've got some new stuff coming down the pipeline here, some new interest in tendinopathies. There's some new research out on that. So in future podcasts, as we catch up here, they're going to be hearing some more stuff on that end. So that's it. Here comes the band and then the podcast. Sorry about everything. Enjoy regardless. Take care. All right, we're back for another show. Sean Allen here. I got on the line good friend Dr. Ivo Airlop. We're back for another podcast, number 125. And last week we did, 2 weeks ago, we launched the one on Achilles tendon, and it turned out to be the most downloaded show we have done to date. So you may want to check that one out. And I do recall we went over some pretty heavy topics, some very important ones. And so much so that I went back and listened to it, and I picked up a couple more things from listening to you more closely. It's funny how when you have a conversation, you you kind of get wrapped up in the dialogue or the rhythm of it, but you miss some germane points. It's kind of like reading something a second time. Sometimes you pick something else, but because of that success, we continue to see this trend ramp up, and we're deeply into 5 figures in our downloads, and we just had several more thousand just in the last couple weeks here. So things are continuing to ramp up. We're getting lots more listeners. We had over 1,000 new subscribers in, I think it was last week. We had 800 or 900 new subscribers. So some big numbers pumping out here, and we're very excited because it means our information and our message is getting out there, and that's always a good thing. Would you not agree? Yeah. That was a fun podcast, and I know we try to, or we don't try to, we end up recording a couple in advance. This is number 125, and we're going to launch 123 here tonight or tomorrow for you folks, but you won't know that until you hear this one. So, but anyways, that's the one drawback from doing these things in the future, if you will. So, but we've got a great show lined up here, and we've got something kind of exciting here. I don't know whether to believe it or not, but we're going to mention it because I do think that somewhere down the line this is going to become a reality. And I got a real funny text from you earlier today saying, hey, I'll see you on the podcast when we talk about brain transplants or head transplants. And that's what this one's about. Cryogenically frozen brains will be woken up and transplanted to donor bodies within 3 years, claims this surgeon. Who is out of the Turin Advanced Neuromodulation Group. I believe he's in Turin. Is that Italy or Spain? But I don't know whether to believe this or not. A lot of this life extension stuff, and this one they were talking with the Alcor Life Extension Foundation, where they basically take these people's brains, bodies, and heads and cryogenically freeze them in the hopes that with advanced technology, which this gentleman says that he suggests that he has, that we can then take these things out and transplant them into another body. And in this case, he's talking about taking the brain and transplanting it into a new cranium and thus on a new body, which is a little scary. We're getting deep into the sci-fi movie stuff here, aren't we? Yeah. I don't know. He was saying that within 10 months, they may be able to start beginning trials on these brain transplants. And why are we in the world are we talking about this on a gait podcast? Well, I mean, if they can do that, we're pretty much guaranteed they're going to be able to make a lot of changes in somebody's gait in terms of all of the things we've talked about in the neuroscience sections here of putting gyroscopes in at the joint replacements and all kinds of interesting things. Although it's very interesting. Yesterday I had a consult from an outside doc, and this lady had come in for a synthetic cartilaginous cap surgical transplant or surgical implementation into her big toe. She had a degenerative, painful first metatarsal phalangeal joint, and apparently she had a full range joint, but it was painful, and she was in her early 40s, and the specialist said, hey, you're in the perfect age range, you've got good range of motion, but you don't have any, but you only have pain. And the joint was only modestly arthritic, but post-surgically she has a functional, maybe even a capsularly restricted hallux limitus and more pain than ever. And this jelly bean-sized piece of cartilage that they were supposed to put in between the metatarsal phalangeal joint, between the head of the metatarsus and the first phalange, I guess they had to drill into the bone of the head of the metatarsal in order to fixate this thing. And I'm not sure if all the bleeding in there caused a problem or not. My first experience with this one, I've seen joint replacements on that toe a couple years back, which was a catastrophe for the client. But weird stuff tends to come in here. But heck, if they can get brain transplants right, why can't they get a toe transplant right? I don't know. What are your thoughts? And have you seen any of these toe things? So just for you folks, if there's a little bit of an editing problem here, Ivo's computer went into a crapshoot there, and so if there's a little bit of a gap or choppiness here, it's because I had to edit around some missing information. But so we're talking about these brain transplants, and I asked you if you had seen one of these metatarsal phalangeal synovial joint jelly bean inserts type devices. And then my next question for you is, how is it possible that they can do a brain transplant? I mean, aren't we talking about all these long spinal cords ascending and descending? I mean, if they can do this, why can't they get around spinal cord transections and, for para and quadriplegic? So there's two questions for you.
First question, I've only seen one of the first MTP joint replacements that have been good. In other words, the person had actually more great toe or hallux dorsiflexion than they did previously. A lot of times it's limited, and we all know that if we don't have forefoot rocker, that's going to create all kinds of other issues. We need about 50 degrees of great toe dorsiflexion. You can get away with 45, but the less great toe dorsiflexion you have, the more you have to spin that leg internally or externally to get over that first MTP to ambulate forward. Your second question, I read this article. At first I didn't know if it was like a goof or something. So first, to clarify for people, they're not doing a brain transplant, they're doing a head transplant. They're severing the head at the neck and transplanting that onto the body. Evidently this has been done with one monkey, and they're working with a group of Chinese scientists to try to do this. I don't know, man. There are a lot of tracks and pathways there. And to, first of all, just be able to get them to hook up, never mind the hundreds or thousands of neurons that you're trying to get to go together, unless there's some sort of new nanotechnology that I'm not aware of that helps neurons to knit together. I don't know. They may be able to transplant the head on the body and have the head be able to function for some of the basic functions. But I don't know. I'm a little dubious about it. Plus, the fact that they what's the word I'm looking for here? For that person to be viable, and then you have all these other issues. It's like, well, what's it going to be like? Now you have somebody else's head and mind and memories and everything else in a different body. Is that even going to function? Is it going to reject it? There's lots and lots of questions. I think probably, and this is pretty far out too, and to say that they're going to do this by 2018, that's I don't know. Probably more likely that we might be able to take memory or data from the brain and translate or transpose that into another brain, that's probably somewhat more likely. But my gosh, just the whole thing, I don't know. It remains to be seen. It reminded me of, the first thing I thought of was the movie Sleepy Hollow, with Johnny Depp and Christopher Walken as the Headless Horseman. And then the second thing came to mind was the movie Free Jack, where they basically transplanted minds. They were taking Emilio Estevez's mind and sticking it into Anthony Hopkins, and Mick Jagger was the bounty hunter. It was a very interesting flick from, probably the 90s. But anyway, I don't know.
Yeah, I don't know either.
I have my doubts.
My first thing was Donald Trump fake news, but I don't know. And I don't know if it goes in this place or not, but I thought, well, we've been talking about them rewiring in brain chips. We've talked about this in previous podcasts. We've talked about them rewiring in nerves back into the new devices. Controlling the brain through brain waves and Bluetooth to move a prosthetic. I mean, things seem to be moving very fast. I didn't think we'd be seeing this one pop up, and I will certainly be looking in the news to see if this is, it wasn't from The Onion, but I certainly, I had a raised eyebrow and a jaundiced eye, but they did bring up a good point here that they say here, in a few months, we will sever a body from a head in an unprecedented medical procedure. In this phase, there is no life activity, not in the brain, not anywhere in the body. If we bring this patient back to life, we will receive the first real account of, what actually happens after death. The head transplant gives us the first insight into whether there is an afterlife, a heaven, or hereafter. So I don't know. Who knows? But, I think that something like this is eventually going to hit. I can't see how it's not with how things are moving so quickly in terms of neuroscience and surgery and technology. Things are moving awfully quickly. So, but
I don't know. It's interesting.
Stick to Donald Trump fake news on this until, keep a jaundiced eye, I guess. Go ahead.
Yeah. Did you notice the picture where the one professor, Canavero, the guy that's kind of helping to pioneer the procedure, they have a picture of him, of an interview or a spread done in magazine, which is a German magazine. Did you notice that it's either an autopsy or cadaver lab that he's
I did notice that, yeah.
posing in? Yeah, I just thought that was sort of like, No. But anyway, it'll be interesting and remain to be seen. So you've heard it here first on The Great Guys.
The great guys, the gate guys, the gloom guys, I don't know. But anyways, let's get into something that probably is a little bit more scientifically relevant here. Running and spinal discs. This was in the news just last week, so middle of April. And there were some other articles in early April, if not March, on, I have one here, the incidence of spontaneous resorption of lumbar disc herniations, a meta-analysis. I've got that in the show notes, and I've got another one that has a whole list of, a link that's got a whole list of references on disc resorption and conservative care and the incidence of improved-looking MRIs post-conservative care. And we used to think that these things didn't resorb. They didn't change the way they look. There are some studies out there that support that is the case. But there is some stuff out there now that is suggesting that, one, it doesn't matter what it looks like, it's how it functions. And two, it can resorb a little bit, and your pain can go away. So these things that we used to always do surgery on are no longer on the high-end surgical list unless, as I say, until you have neurologic decline, preferably in the motor category. Pain and sensory stuff is not a surgical marker or correlative for surgery. So, I always look for that neurologic decline, and that's when you got to boogie and start to move, because it might not come back. So anyways, running and spinal discs. Did you get over to this one?
I did. It was an interesting study looking at the effects of basically chronic compression/decompression cycles on the lumbar spine. And I thought it was interesting and viable. Basically, this is just another reason for people to run more, as far as because it has shown that these people have increased signal uptake or increased water ambition in their discs compared to controls. And it wasn't an enormous cohort. It was a small study. It looked at 79 individuals aged between 25 and 35. But I would preface to say that, so first of all, they did the study looking at runners versus non-runners to see if it had an effect on the disc. And what they found is that people that ran had higher T2 intensity on MRI than physically healthy but inactive folks. But I want to put the caveat here in one thing. So everybody's like, oh, I need to run more and more. Well, first of all, the study was done on a narrow range of people, sort of younger sorts of folks. Number two, they ran at a specific speed.
Mm-hmm.
Okay, and the specific speed translates to about 4.47, so just under 4.5 miles per hour. And three, there was this very specific dosage. It was 20 to 30 kilometers per week, okay, which is 12 to 15 miles. So this looked at that very narrow sample size, and we don't know if we looked at longer or shorter times, if we would, what the minimal effective dose basically would be for these individuals. But I thought it was interesting, and it really wasn't surprising to me. I hadn't thought of this before, but it wasn't surprising.
Well, they talk about, germane to what you were just talking about there, they looked at, and I'm just going to use the metric because we have a lot of, you just gave out the imperial stuff. I'm going to give the metrics. 2 meters per second. The ambulation at 2 meters per second fell within the window that they observed, while walking at less than 1.5 meters per second or running greater than 2.5 meters per second fell outside. So these people that were in the 2 meters per second fell within that window where there was an improvement in the appearance of the disc or the hydration of the disc, the proteaminoglycan content or hydration. So if you went too slow or you went too fast, which increased the impact loading and acceleration, that tended to slough off some of the improvements, if I am correct, because they were looking at upright axial spine loading and intensity. So they were talking about this anabolic window, which is certainly, it sounds good, on disc loading. And they suggested that there's this anabolic window, and that's they found around 2.0 meters per second. And at you said, what was it? How many miles per week? 20 to 30?
It's 20 to 30 kilometers, which translates 12 to 15, approximately.
Yeah, miles. Yeah. So they did admit that this study is limited in its cross-sectional design. And as they said, the team considers their research to be a first step concluding that these findings will be a starting point for better. They typed it sloppily here. These findings will be a starting point for to better define exercise protocols and physical activity profiles for intervertebral disc anabolism in humans, the anabolic effect, if you will. So, you got to be very, very aware of what these studies are saying, and they're even admitting here that correlation is not causation, or in this case, this study has some limitation. And again, don't take this as I need to run more, as you said very wisely. What this is saying is that with some appropriate speeds and appropriate distance, they tend to think that maybe the disc is getting a healthier loading response, and things that are appropriately loaded over an appropriate number of cycles, appropriate number of compressions or compression rate or intensity may actually help that disc stay a little bit healthier and be more anabolic, if you will. So I don't know. It's interesting. They did talk about things like golf, where there's a lot of flexion and torsion, which we know would probably be negative. And in this case, this is upright loading without a lot of that rotation. So it seems to be a safer loading response. But I don't know. You have anything else to say on this one?
A couple things. Wrap your noodle around this. Let's just accept that the study is what it is, and that people who run these distances in this particular age group have more water hydration in their discs. Okay, let's just accept that. So the question becomes, number one, And you had mentioned the glycosaminoglycans and the proteoglycans. And those are the protein components that have a large negative charge that attract the water, that actually cause imbibition of water into the discs. So, number one, is this phenomena purely a mechanical phenomena? In other words, it's like a sponge and we're constantly compressing and decompressing the sponge and it causes it to absorb more water. Two, is it purely a chemical phenomena? In other words, is something happening because of that stimulus and because we're doing aerobic exercise and the call for oxygen will be greater, and we know that when we exercise musculature in an aerobic fashion, we will get one, increased mitochondrial content, two, increased myoglobin content, the energy stuff, as well as three, increased glycogen, and four, increased capillarization. So is it some stimulus which is stimulating that? Or is it a different stimulus whatsoever? Is it a neurological stimulus that's actually causing this because of balance coordination, forward motion, and coordination with the vestibular system? So regardless, it's good being active, moving, these body weight forces times acceleration due to gravity certainly seem to have a positive effect on the discs. But what's causing that? And once we figure that out, can we somehow harness that in a good way?
Yeah. One of the questions I get a lot from I have some weightlifters, some powerlifters, a lot of CrossFitters that come into my office. What would be your comment to them on if I came into your office and said, look, I love my running, I love my aerobic stuff, but all the new literature says that runners do better if they do some heavy lifting to try and develop some durability into some of these joints that tend to go awry in running, hip stability in the frontal plane, those types of things. If they asked you what are the risks on the spine and the intervertebral disc, hey, Dr. Ivo, I've got some degenerative discs in my back. Should I actually entertain that lifting, or should I, move away from it? Is it dangerous for me? I'm not sure what you or Dr. Stu McGill would say, but what do you think? I know that if you have some pre-existing things like some end plate changes in the vertebral body or some Schmerl's nodes, if you will, whether they're active or inactive, they can cause some abnormal end plate loading up into the vertebral body, which can also certainly change the way the disc works in terms of compressive loading and internal pressure within the nucleus of the disc. But what would you generally say if someone came in and asked that question? Should I add this, and is it safe?
Well, one, being a fan of lifting up heavy things, I think that, I would not discourage somebody who wants to exercise from exercising. I would caution them that things need to be done at an appropriate, weight, speed, and exercise dosage as far as that goes. And it could be beneficial if done within the appropriate parameters depending upon what's going on with that individual and does it have a tendency to flare their symptoms or not flare their symptoms. It's walking that fine line between just enough and too much as far as, exercise dosage goes. I generally don't discourage anybody from exercising, especially if it's something they want to do. It may not be the ideal exercise, and I may try to steer them towards something else. But we see tons of people with osteoarthritis that we encourage to remain, active and doing things, because that's ultimately not just the effect musculoskeletally on their discs and their vertebrae, but there's such a cognitive effect and a muscular effect as well as a neurological effect that's going to occur as a result of the exercise that may outweigh some of the benefits of, outweigh some of the risks that are going to be involved with some of the other stuff. So if I was concerned solely about, disc height or something like that, maybe I would recommend running in light of the study that we talked about. But in light of if running causes back pain, then I would probably be like, look, we need to get your core stable first before we start applying axial loads with your body weight times the acceleration due to gravity, since you can't even hold up your body weight. So, it depends, just like everything else, and we always say this. You can't just, when they have this, you do this. It really depends on what you find on your exam, what you do, We always call them diagnostic trials in the office of whatever, whether it be manipulation or exercise, orthotics, needling. And then kind of tempering that and weighing it and tweaking it so that it works best for the client.
Yeah, I mean, my answer would generally be the same, that, adding durability and strength and more loading around a joint, as long as it's appropriate loading and safe loading for that person, is never a bad thing, as long as they're doing proper lifting and proper loading responses through multiple joints and they've got all the right patterns and skills. It's generally a great thing, even if, in this next topic we'll talk about bone density and stuff, but in general, I think it's a great thing, and it should be part of your workout. I think a workout is incomplete if it doesn't require or include some heavy lifting. It'll come back to me. It just completely left my noodle. It was a feed off of something that you had said. You're talking about running. Come on, come back.
I was talking about running. I was talking about increased signal uptake.
Yeah.
It's gone, folks.
It's gone, folks.
Sean is having a Prozac moment.
Sometimers is kicking in, yes.
Sometimes.
Anyways.
Yeah, we call it CRS.
CRS.
Can't remember stuff.
Yeah. Let's go on to the next one here. I know, obviously,
sure.
Brain fart here. A lot of folks, although this is decreasing, I still have clients that are a little bit on the knucklehead side, and I take my non-steroidal anti-inflammatory, whether it's acetaminophen, ibuprofen, naproxen, blah blah blah, before my workouts, or I'll take them right after my workouts. It's almost like it's a vitamin. It's part of their daily regimen. I don't know if they're afraid of pain or they just... Actually, I do know what it is. A lot of these people think that taking this thing is going to pull down enough inflammation that its benefits outweigh its drawbacks. And here's the thing. I don't think people think there are any drawbacks. So this article in Time magazine, and there's been many other articles, so we don't need to go into those, but it's been more and more coming out there, especially in the last few weeks, about the detrimental side effects of over long periods of time of taking these things, from heart problems, which was the newest one in the news, to kidney and bone density, and even hearing loss. And we'll go into some of those stats on this. But to get clients that are kind of prophylactically taking this stuff because they're afraid of, and they think they're afraid of pain or inflammation, or they think it's going to benefit from it, or are you guys a little bit more wise out there up in the mountains?
I think we still have people that take vitamin I on a regular basis, as far as that goes. And it's, we always talk to people about it. It's, I don't have a problem with people using anti-inflammatories as long as you understand what the risks, versus the benefits are. Inflammation is part of the healing response. So just like with acupuncture and needling, if people are like, oh, it's really sore, I'm going to go take some ibuprofen, I'm like, well, that's fine, but you're going to decrease the healing response. You really need to give it 24 to 48 hours before you start doing this, because the local tissue as well as the nervous system is looking for that feedback about the inflammation to actually create a healing response. So if you shut down the prostaglandin pathway and you shut down some of the IL-6 and TNF alpha and all the other inflammatory mediators that basically upregulate NF-kappa B, all of a sudden now you are not going to get as good of a response. And when you look at people, the studies that look at people that take NSAIDs regularly, they get a poorer healing response. It inhibits collagen cross-linking, so they get a weaker, poorer scar. They have less pain, but they have a weaker, poorer scar. And believe it or not, even not just the inflammation, but the pain aspect of it is necessary for a portion of the healing process too. We have these descending inhibitory pain pathways. There's actually 4 of them that descend down from the cortex, which are for controlling pain. And if we shut that down, we lose some of that descending inhibition. And with that being said, I'm not don't ever take this stuff. I'm just saying know what the risks versus the benefits are. If you're in a lot of pain and you're having trouble and you got a hot, low back, knee, ankle, insert body part, there, it might make sense to do something like that at night so you can get some rest, as far as that goes. But, NSAIDs have the 3 basic, bad side effects. 1, inhibits collagen cross-linking. 2, they cause osteoporosis. And 3, there's the gastric side effect, where they can basically eat through your stomach lining. I mean, I've had at least 2 patients that I can think of, one in recent memory, that have had to have kidney dialysis and ultimately a transplant because of overuse of NSAIDs for other stuff.
Wow. Yeah, I remember sitting in a David Seaman seminar. He's got a company called Deflame. That joke just popped into my head. You know where I'm going with it. The plane from what was that show?
That was from Fantasy Island.
Fantasy Island. Yes, Mr. Rourke and Tattoo is his name. Tattoo Deplane. No, David Seaman's website is Deflame, as in unflame, and it's a website about inflammation and good dietary habits. I remember sitting in one of his seminars decades ago, and he said, look, I don't have a problem with anti-inflammatories. The detrimental effects of a loss of night of sleep on many aspects of your physiology is way more detrimental than taking some ibuprofen and getting a good night's sleep. So I don't have a problem with it either. It's just when you abuse it. And some of the studies, here's one that said that high doses of NSAIDs, non-steroidal anti-inflammatories that is, increased risk for heart attack and other heart problems by 1/3. Ibuprofen in particular more than doubled the risk for major heart event. Another recent study involving 10 million people found that those currently taking NSAIDs had a 19% higher risk of being hospitalized for heart failure, 10% higher risk for developing hearing loss. And even out of the University of Saskatchewan in Canada, their study on bone density, they took, it doesn't really matter the details here, but people who took non-steroidals just before they did resistance training experienced more bone loss than those who did not use the drugs. And that's because of the inhibition of the prostaglandins, which help to build bone. They inhibit the release of the prostaglandins. So these are powerful drugs, and we tend to not take them seriously because they're over the counter. But a lot of things go on here. Plus, you got to throw a liver in there to metabolize this thing. And there's a lot of things. You're changing your physiology when you throw something like this in here on many levels in many different organ systems. And you have to understand what your risks are. And a lot of people don't know that they're risks, so they abuse these a little bit. So, all right. Windswept biomechanics. What the heck is that? We've had people ask this before. You did a post on this. Oh,
I did.
Was it last week? 2 weeks ago?
Yep.
And can you explain what Windswept biomechanics are?
Sure. They are when you have an aversion to wind when you go outside. No, only kidding. What Windswept biomechanics are basically like somebody that has external tibial torsion on one side and internal on the opposite side. So their feet look like the wind has come and brushed them from one side to the other. It's largely a congenital thing. It has to do with how the feet are positioned in utero. Usually it's left leg over right, but sometimes that can be different, or there can be different pressures on that will cause that. And what normally happens is because we are born kind of dink-toed, our toes point in, we're supposed to get slow external rotation of the extremity over time at the rate of about 1.5 degrees per year from about age 2, well, from birth basically, till about age 12 or 13. Resulting in that normal slight toe out that we see on either side. And depending upon what the position of the lower limbs are at birth, that either can occur appropriately or inappropriately. And as a result, we can have these things. So pretty much what that means is, let's just say they have external tibial torsion on the left and internal on the right. More than likely, and this again is indefinitive, they're going to have a tendency to pronate more through their midfoot on the right-hand side, whereas they're going to be in more of a supinatory moment, on the left-hand side, and more of a supinatory moment on the right-hand side. And as a result of that, if I'm pronating on the right, I'm going to get anterior nutation of the pelvis on that side. If I'm supinating on the right, I would have posterior rotation. So on the left, if I have ETT, I'm going to see anterior rotation of that ilia, and on the right side, if I have ITT, I'm going to have posterior rotation. So now I can get pelvic distortion that's going to occur as a result of that. And I talked about that a little bit in the post that we just kind of went through it and been doing those case in 1 minutes which are just kind of nice little capsule summaries of some concept that are, they're actually not a minute. They're usually about 3 minutes or so, but just kind of capsule summarizes some of the stuff that's going on. And I have to say, for the people that are listening here, I was very disappointed to see, I put a ton of time into this one that I did on, and you probably saw it this week, the one that I did on people with metatarsus adductus. And I really put a lot of time into that, and not many people watched it. I was like, really?
Neither did I. I didn't watch it either. I'm just kidding.
Thanks.
I did.
So
I did.
I'm just a geeky guy that's into congenital abnormalities for the feet. But anyway, it had some really good clinical information there, and maybe after this, people will go back and look at it. You can find it on the website as well as on our Facebook feed. But I was, I see patients with this quite a bit with forefoot adductus or metatarsus adductus or metatarsus varus, which is actually a variant. So I kind of went into it and explained all the, fine little details in it.
Yeah, I think that that stuff can be intimidating, Ivo. The bony torsional stuff. I mean, most people don't have a good grounding in true foot biomechanics. Their world exists from pronation and supination and too much of either one. Maybe not enough ankle rocker, but they don't understand these more global biomechanics. And then when you throw in, forefoot adductus and rear foot inversion combined with internal tibial torsion and femoral anteversion on the opposite side with a Windswept biomechanics and a pelvic distortion pattern, their head explodes. So I think some of that stuff is just, it's intimidating, I think. And when I sit down and look at that stuff or a post you've written on it, I got to have a quiet room, cup of coffee, and then I have to have my thinking cap
coffee
on.
So you can stay awake?
Yeah. But it just requires some attention because that stuff is complicated. And the more you know, the more factors that stuff plays into the normal biomechanics. And then, a patient walks in with it and they've got their own clinical issues. So it's complicated stuff. I don't think that, I don't think people do that in intention. I think it's maybe out of aversion to fear or the complexity of it. I mean, not everybody's like us and they want that mental gymnastic stuff, nor do they have time for it. They want that quick, easy feed. No offense, but I'm the same way. So I don't think it's anything other than great material, and I don't think that's the comment. It's tough material, and I'm a sissy today kind of thing. So
you think they have adductophobia?
Yes. A torsion phobia and congenital, all that stuff.
All right.
So
well, anyway,
the Windswept stuff.
Back to Windswept, yes.
Yeah. Whenever I see that person lies on the table and the left foot's turned in and the right foot's turned out, the first thing I go is, whoa, okay, we got some asymmetrical hip biomechanics here until proven otherwise. Too much internal rotation on one side and too much external rotation on the other. I guess I better see if they're missing the components that drive those things in the opposite direction. The first thing I'm going to look at is, well, I'm sure you've got a functional leg length discrepancy. Let's go watch your walk and let's see how well you can hold that pelvis level. And if you've got a pelvis drift in the frontal plane to go along with that windswept biomechanics, is it following the distortions, or are they working against it? That goes back to what I always say. You're going to have clients that follow the deforming forces, and you're going to have those clients that fight the deforming forces because their system knows that going further may cause pathology, trauma, pain, etc. I find it always interesting that those clients typically fall into two categories. I would have to say that the ones that fall into the deformity are probably the ones that are more likely to come into the office because they're more likely to have pain, but that's not always the hard case. So, the first time I heard Windswept biomechanics was at a seminar that you and I were at, and I was like, oh, that's an interesting concept or way to describe it. I like that. And so you feel that these things are generally more congenitally bone torsional related as opposed to functionally muscular asymmetry?
Frequently, but not always. You can certainly see people that have normal amounts of torsion that have it because of other things. And to just kind of back up, I remember the seminar you're talking about, and I can't take credit for coining that. That was a Sean Enoism and a Peter Morin-ism. Those are things that podorthists that I've worked with and studied with in the past, they kind of came up with that, and Gerhard Rail and a few of those people. So I just sort of borrowed their language. But I would say more often than not, there is a component that's congenital, but not always. It doesn't have to be that way. People that have very asymmetrical jobs, as far as function, factory jobs and stuff like that, where it's very repetitive motion in one particular direction or another, a lot of times have these things.
Yeah, and I know over at the Grip Approach with Ben Fergus, they're having Sean Eno come in to do a seminar, and I know a lot of those people over there listen to our work. And I think the one caveat, Sean Eno is very intelligent. The one caveat is that for those listeners from that categorical group, remember that Sean's experience past that stuff in terms of foot and biomechanics and pedorthics is a little bit more on the limited side, and that's not a detractor from his brilliance, because he's probably one of the smartest foot guys. I mean, boy, his mind's going a million miles a minute, and there's few people that will be able to juggle with him or spar with him cerebrally when it comes to foot biomechanics. So that's a huge pat on the back for him. But you got to look north as well. What's the knee doing? What's the hip doing? And if your answer is to take these biomechanics and always put a orthotic on it to correct the biomechanics at the foot level, you need to make sure that you're also looking at, well, can we amend some of these things by looking at the biomechanics higher up? And of course, the answer sometimes is, well, we need to do a little bit of both here and use the old orthotic therapy standpoint that you and I like to look at of, well, this is temporary. This is going to help us get back to where we need to be. My approach tends to be, I'm going to fix as many biomechanical things as I can. What I'm left with then is going to be what we devise an orthotic footbed wedging system around, or some different shoe choices. However, those types of clients tend to be willing to say, well, I'll deal with the pain until we correct this. But some clients just face it. They just come in and they want to be out of pain, in which case I think the other approach is a little bit more abrupt in getting to that goal. So, all right. So, foam rolling a big thing in your office? Because this article here we posted up a couple weeks ago certainly raised my eyebrow, and I wanted to know what you thought about it. But you guys sell foam rollers in your office? There seems to be two camps. Two camps. Foam rolling is useless, or foam rolling has a purpose. I tend to be on the side of, look, it's probably not going to hurt anything. It's probably only going to help. I mean, I don't think you're mashing out soft tissue and making things change like rolling out dough, but I do think that you are doing something neurologically and neuromechanically in stimulating tissue and receptors and whatnot. And this article here suggested that arterial blood flow of the lateral thigh increased significantly after foam rolling exercises compared with baseline. So you guys do sell these in their office. Is it something that you promote? Do you tell folks, look, here's an Intercell stick or a foam roll or a rumble stick. I want you to go ahead and, work on this area in conjunction with the corrective homework that I've given you 3 or 4 times a day, and I'll see you in a week. Is that something that you do, or is that something that you just have your clients do at the office, or do you just let them just kind of do whatever foam rolling and sticking that they want to do on their own?
We utilize all of the above. A lot of times people are really attached to and into their foam rolling. So I don't want to detract from anything that they're doing that could have a potential positive effect on their outcomes in my office. So I don't have a problem with that. There was a great spread in Lower Extremity Review probably a year ago. And it was basically the latest, greatest on foam rolling and what all the current research had said. And you can go back and search through the blog or search through Facebook and pull that reference. Or you can just go to Lower Extremity Review and type in foam rolling and pull that up as well. It's something that we recommend at times, again, depending upon the individual and what's going on. There's certainly a proprioceptive as well as a mechanical component that's going to be affected by foam rolling. But that's not the only treatment that we're going to recommend. It's in addition to, yada, 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 whatever else we happen to be doing. So, yeah, we use that. We sell foam rollers. We only have the black ones, the coal rollers, just because the white ones are they compress out so fast. And people that the black one is not hard enough, we just send them to Home Depot and tell them to get a piece of PVC pipe and roll on that because, that's nice and hard and it's way less expensive than buying one of the super duper hard ones for $50 or whatever.
Well, the nice thing about the PVC, by the way, the nice thing about the PVC is if you just cut a short, maybe 2 foot long one, it'll fit in your carry-on luggage, and then you can stuff socks and underwear and T-shirts into it. It doesn't eat up any room at all, and you've got your therapy there. So you may get a little bit of a eye raising when you check through the TSA, but you can assure them that there's nothing in there except some dirty socks and some smelly underwear. But it's one way to get around it and travel with a foam roller without actually traveling with a foam roller. So sorry to cut you off.
Oh, no. And it's also great if you get someplace and you need to repair a sewer line, and you got that 2-foot section with you. A lot of times you can, I always bring a little PVC cement with me as well. That way I can kind of do that repair on the fly. Just one of the many services we offer from the Gate Guys.
Touche.
No, that's a great idea. And you can also take the coal rollers. Of course, they're significantly larger, but you can lop off a section. Of course, it's not hollow at that point, but you can pack those as well. So this particular study looked at arterial blood flow in the lateral thigh, and they showed that when you foam rolled compared to baseline, it increased fairly significantly immediately after. So they looked at basically flow max using the Doppler, and then total flow, and then they looked at a average of the flow pretty much. And what they found out is that immediately following, it increased flow by like 73%, and then 50% at about 30 minutes, it was still, still increased. So the question, of course, arises is that, well, we're increasing blood flow, so is that a good thing or not a good thing? So if you've got a lot of inflammation there, increasing blood flow to an area with inflammation, you could make the argument that, yeah, it's going to help wash away those inflammatory end products, that we always hear about. But you also have to think about it's like pouring gas on a fire. And it could potentially make things significantly worse in that. But, the mechanism physiologically probably is, one, just through muscular compression. It's causing a vasodilatory, response. You're probably stimulating histamine release, somewhere, probably mast cells, but it could be other things, as well as a mechanical response. And in muscles, we have those alpha receptors, and alpha receptors are what are going to cause vasodilation peripherally. So the pain or uncomfortable component, along with a mechanical compression component, are probably stimulating that and causing localized vasodilation, in addition to any local tissue factors that might be released from the cells, in that particular area there. They didn't check significantly later than 30 minutes, which would have been interesting to look at them like an hour or a day later. So how long does the effect last? But if it's increasing blood flow, maybe this is something you want to have people do prior to exercising. Kind of like as a warm-up, because people love to warm up, right? They love to stretch, and static stretching, is it's certainly not going to be injury preventative, but it may be beneficial from a cerebral standpoint for individuals. But something like this is going to increase blood flow, so that could potentially be a good thing. You'd have to foam roll an awful lot. In this particular study, they did the lateral thigh, but they also did the med/min area, and there was no change there. So the major change was in the lateral thigh. So keep that, under your thought pattern as well.
Yeah. Well, I won't be the first to say that there are some studies out there that suggest that, for example, if you're trying to lengthen the hamstrings, just some foam rolling into the hamstrings prior to activity will give you just as much change in the length-tension relationship as passive stretching will, with the advent of having more activation and, according to this, probably some increased blood flow. So I always tell my athletes, lots of foam rolling before you go out for a run. Don't do any stretching. Lots of warm-up, whether that's, some calisthenic type stuff, bridging, shuffle walks, all the stuff that we like to do, some monster walks to gain that side-to-side frontal plane hip stability. And then some good foam rolling, and then go out there. But a lot of people just put on their shoes and they go. And, kudos for you if you can get away with it, but how long can you get away with it, I guess, is the answer. And, hey, what's 5 minutes of preventative stuff to actually perform better and maybe fend off some risks? So that's the way I try to sell things. So,
in worse scenarios, they can always get a head transplant done,
Absolutely, yeah.
Exactly, yeah.
I need to borrow your body because you seem to be a little bit more limber, so we're just going to take my head off and put it on your body.
There you go.
So we all could, you and I could eventually maybe make it to the NBA,
Yeah. No thanks.
Yeah.
Not my thing.
two ugly heads on great physical specimen bodies. It's one way we can get around these ugly looks of ours, huh? Little head transplant thing there.
Yeah, there you go. Anyway, hey, you put this thing on about myokymia, so I want to hear what you have to say about it.
Well, dude, I don't have much to say. This thing was over on Twitter, and there was a poop storm over what this thing was. There were some runners over there at, I believe it was in the Boston Marathon, and some of these photographers with their uber fast cameras were able to capture these guys in mid-stride and mid-swing, and they found some consistencies in a couple people of these look like horizontal striations moving up and down the front of the quad. And I happened to notice that it really didn't look like it was in the rectus femoris because it was such a wide distribution, and it didn't seem to match the vastus medialis or lateralis either. So I was wondering what you thought of this. Did you have a chance to look at the pictures?
I looked at the pictures, and at first I was looking strictly at their mechanics, not at the swing-faced leg that you're seeing this phenomena in. So I kind of got caught up in like, oh my God, look at what's going on with this guy. But then I looked at it later after you sent the myokymia piece over. I'm like, oh, okay, well, maybe that's myokymia. But like you said, it really doesn't correspond greatly to a distribution. You've got basically vastus intermedius and rec fem distribution, at least on the one individual that we can see coming across, but it seems similar in both. It may just be that you're seeing individual or groups of sarcomeres of muscle going through eccentric contraction as that person's coming through. They're at about mid-support at that phase in their, actually one's in mid-support and one's just prior to mid-support in their running cycle, and maybe that's just what you're catching because of the high-speed camera. Myokymia is pretty specific, and I don't know if this would constitute a myokymia.
Yeah, I don't think it fits. Myokymia is a form of involuntary muscular movement. Usually can be visualized on the skin as vermicular or continuous rippling movements. And, I don't know. I don't think that's what it is either. Do you think that it could be, first thing I thought of was, well, with the impact loading, and was this just soft tissue, fatty, fascial plane rippling up through? But, I mean, these guys were pretty jacked in terms of low percentage fat, so I just didn't think that was it either. I don't know. I've yet to go back onto Twitter and see if the storm of tweets on this and the dialogue has come to any more conclusions there. But I just thought it was interesting, and this one is over on our website and Facebook feed. The week of I think it was around April the 20th or 22nd, somewhere around there. So you guys can go ahead and look at it, but these weird horizontal striations, which we've seen in bodybuilders when these guys are down to single-digit body fat, but this just didn't look like the same thing. It was thicker striations, and I don't know, it was a weird distribution. I certainly thought it was bizarro. So, but kudos to Ross Tucker and Adam Meekins. Those are the guys that were starting this trend over on Twitter, and we will have the links in the show note for those Twitter accounts that will get you over there to see some pictures. So,
do you think it's possible, not plausible, but possible, that now these are, high-end runners and stuff, but we all know with running that you can sweat as much as 3 liters per hour, but your body's only going to be able to absorb about 24 ounces of fluids, give or take a few, per hour. And if these people are later in the race and they're somewhat dehydrated, do you think you might actually be looking at skin friction over muscle because of dehydration in the extracellular compartment? These are people that are, pushing the envelope as far as from an athletic standpoint, and they don't have any body fat to spare, as far as that goes. And are we just seeing that? Sort of like if you take a rug, and you push it in the wrong direction for just a second, it kind of buckles up for a few seconds and then not. Because if you look at the two pictures, you'll see that it's very similar in distribution as far as where we're seeing that.
Yeah, I think it's something probably more like that. So there's a differential between the slippage of the skin and the tissue beneath it because of the dehydration. Almost like you could take someone who's dehydrated and pull their skin away, right?
Right, and I'm not saying it is that. I'm saying to me
Yeah.
that would be a logical explanation. These people do not have any
Hmm.
body fat to spare.
Yeah. Yeah. I mean, with this, again, with the width and thickness of these striations, which don't seem to be the normal striations that we see like in a bodybuilder, I think something like that is way more plausible. But you guys go ahead and have a look and send us your thoughts if you'd like to. Hey, let's finish with this last ankle proprio one, unless you got some other dialogue you want to hit on.
I'm good.
Okay. Let's see.
So you're talking about the proprioceptive deficits in people with chronic ankle instability?
Yeah. Go ahead and hunt that down. It was just kind of interesting to see things on both sides.
Yeah, this one was just talking about people with CAI, and pretty much
Chronic ankle instability.
Chronic ankle instability, yep. That it was real evident that people with chronic ankle instability, and they differentiate here between functional versus, I forget the word that they use. One was functional instability, the other was mechanical instability. And the functional means that, it was they were appearing unstable, whereas mechanical was they had an actual boo-boo that you could see on MR or CT or X-ray. But the people have impaired proprioception, and that's really in both cases, that's really no rocket science or big surprises here. We know that these folks have diminished proprioception. That's why they have the, ankle instability in the first place. So,
what was interesting, though, is that the individuals with unilateral, and this is right out of the conclusions, individuals with unilateral functional ankle instability had increased error ipsilaterally, meaning on the injured side, for inversion movement detection, also known as kinesthesia, if you will. So in other words, they couldn't sense when the ankle was inverting on that side that they had just sprained, because that was the mechanism of injury, probably was an inversion event. So as they go into further inversion, they are having a failure or an increase in error perception. However, there was also on that same side an increased error for everter force sense. So as that heel goes from inversion, think of tipping the heel out and the foot out, to moving more tipping in, as if you were getting to prepare to go over your big toe. There was an increased error in that as well in terms of force sense. So they're losing this ability to kind of tell how far they're tipping too far laterally and how much load they're going inside. But they also noticed on the other side, the well leg side, an increased error for everter force on that side, or everter force sense on that side. So is this that cross-cord feedback thing?
I think that, first of all, think about the anatomy of the ankle. The mortise. The lateral malleolus comes down much further than the medial malleolus. And as a result, you create this fulcrum where we're going to have a tendency, in most cases, to invert more than we're going to evert. So when we have CAI, it's usually failure of the lateral stabilizing complex of the ankle, whether it be the calcaneal fibula, the anterior talofibular, whichever ligaments on that side there. When we have people with functional ankle instability and they invert more on one side, that's going to move your center of gravity to the outside of that foot, which is automatically going to move it to the inside of the opposite foot, which is going to place an eversion moment on the contralateral extremity. In other words, if I invert my left ankle, I'm going to have a tendency for my body to shift left and put more weight on the inside of the right as my hip moves to the left. So it would stand to reason that if I place that opposite non-affected side in more eversion, there's going to be more error in that area because you're taking a joint more towards the end of its range of motion. Think about your proprioception in mid-range of a joint versus at end range of a joint. It's way better mid-range. Okay, that's where we're designed to work, just like muscular strength. It's strong mid-range, it's weak at the very, very beginning and the very, very end. So I think you're just seeing a function of that here. At least that's my opinion.
Yeah, no, I agree. I do. But, these ankle sprains, we hit on this stuff a lot in the proprioceptive deficits here because these things are chronically undertreated. If you take something just to 90% or 95%, you leave a 5% residual that can mushroom into something different or mushroom into something bigger down the road, or become part of their new normative neuromuscular or neuromotor pattern. And that's not the primary cleanest motor pattern, but that's the best that they can do. And you just let them sit there with this deficit, building motor patterns on that deficit in other areas of the body, which eventually can, but doesn't necessarily need to, but one can theorize that it chips away at some of the stability and durability of the rest of the system. And it's probably why these people have recurrent ankle sprains over and over again, because the last little deficit isn't whittled out of the system and rehabbed appropriately. So I tend to be a real stickler with my ankle sprain patients. 2 weeks non-weight bearing, no activity. They think I'm crazy because they're already walking on it 2 or 3 days later, and they're, hey, the swelling's going down, my pain is going down, and I tend to be a little bit more hard on these ones, especially my high-end athletes, saying, look, we can either pay for this now or we can pay for it later. And if we have time right now, because you do have some pain, let's just treat this thing right. Get off of it a little bit longer. We can do some rehab right away. We can get you into some loading responses that are safe and appropriate. But let's not get you back to activity right away just because you think you can. And no taping or athletic tape or kinesio tape or rock tape or whatever you use. I don't have a problem. Those are all good companies, but it's not going to offset, or a functional brace, it's not going to offset the deficit. It's kind of like the theory of those old abdominal belts that you used to see over at some of the hardware stores that these guys were using when they were lifting stuff. You're just giving that system a crutch to use a device to try and get around a problem instead of strengthening your core or giving them some lifting awareness courses or something like that. And so I tend to be really hard on my ankle sprain clients and say, look, if we leave this, we're going to get some frontal plane hip stability. And it's interesting because you can usually take that client, if they're within 2 or 3 weeks of an ankle sprain, put them on the table and show them the lateral frontal plane glute weakness that's already presenting off of that sprained ankle. So it's usually there. And usually for me, that's a selling point. They now go, okay, I get what's going on here. It's already happening and I'm not even aware of it at that point. So I hit those things hard, and some would even say too hard and overkill, but I'd rather just be safe up front and do it right. So
the question is, do you hit them with the foam roller, and do you give them ibuprofen to reduce the inflammation afterwards?
Yes, and then I show them, photographs of head transplants. What do you have? Brain damage? Get off that ankle.
That's it. That's it. Or I'll give you a head transplant.
That's right. Should have a catalog. Well, which head can we go with? Can I choose a body?
Yeah. Right.
Anyways, all right. It's Dry Humor Friday here. So, podcast 125. Hopefully by this time we have a Patreon account, and if you feel that making a small weekly, monthly, yearly donation or recurring donation is something that you would like to do to support all of our efforts here to entertain you with minutiae of details and nonsense and bad jokes, then please feel free to donate to our cause. So the Patreon account button should be on our website, so head over there if you'd like to make a small or large donation, whatever makes you feel happy. But as I say, if we're giving you something of value, give us something of value in return, or at least consider it. Okay, Ivan and I do take a lot of time out of our day, so to do this stuff and write, and the majority of it has been free for everybody for 7 years. So we're just trying to amend some of our costs here. So feel free to make a donation. We would certainly appreciate it. And for those who do make donations, we will be giving them heads up, most likely, on courses. We're putting together something new here. Can't tell you what it is yet, but those folks will probably get first dibs on those things. So just our way of saying thank you. So until next time, Sean Allen in Chicago.
I have a whirl up in Dillon, Colorado. We will see you later.